Okay, let's unpack this. Imagine a friend comes to you, maybe someone you know well, and they're dealing with this persistent leg swelling. It's been going on for a bit.
Yeah.
And you notice maybe some prominent veins kind of look a little ropey.
Mhm.
And then, even worse, there's a skin ulcer that just won't seem to heal.
Hmm.
Yeah.
Worrying signs.
Absolutely. So what's really going on beneath the surface, and maybe more importantly, what's the very first, most critical step you'd recommend they take to actually get to the bottom of it?
Right. What's that initial move?
Exactly. Today, we're diving deep into a clinical puzzle. And, at first glance, it might seem pretty straightforward.
Deceptively so.
Totally. But as we start peeling back the layers, you'll discover it holds a surprising number of nuances, some really critical differentiators, and honestly, some very common pitfalls, especially, in high-stakes situations like medical exams.
Mm-hmm. Those tricky questions. Our mission really in this deep dive is to guide you through a truly real-world medical scenario. We're going to dissect every single symptom, every lab finding, every potential diagnosis with, meticulous detail.
Getting into the weeds.
Exactly. We're not just looking for an answer. We're really seeking to understand the why behind every single decision. We'll explore the subtle but absolutely critical differences between various vascular conditions.
Okay.
We'll illuminate precisely why certain treatment options are correct and, just as importantly, why others are incorrect. And crucially, we'll highlight those common traps, the things that can lead to misdiagnosis or, inappropriate management.
Yeah, those are key.
By the end, our goal is that you'll master not just the correct next step, but the robust clinical reasoning that really underpins it, so you can confidently navigate similar cases and ultimately provide truly optimal patient care.
Excellent. Now, we're working with a really fascinating case study today. It's a 52-year-old woman presenting with this whole constellation of symptoms.
Right, a classic presentation in many ways.
It really is. And it's a perfect example of how combining a thorough patient history, really meticulous physical findings, and sound diagnostic principles allows us to navigate even the most complex medical decisions and hopefully avoid those tricky missteps that can just derail a diagnosis, right?
Absolutely. It's about building that framework.
It's not just memorizing facts. It's about building a robust framework for clinical thought. Okay, so let's set the stage. Let's paint a vivid picture of our patient. This is really where the clinical puzzle starts to unfold, piece by fascinating piece.
Lay it out for us.
We have a 52-year-old woman. She's come to her physician, and her chief complaint is swelling in her legs. Now, this isn't something that just popped up overnight.
Okay, so gradual onset.
Exactly. She's noticed it gradually worsening over the past 2 months. And here's a really crucial detail she mentions. The swelling noticeably worsens throughout the day.
That temporal pattern.
Yes. And it often feels better after a night's rest, with her feet up. That specific pattern, worse with activity or dependency, better with elevation, that's a significant early clue. It immediately starts guiding our thinking.
Absolutely. That's classic for certain types of edema. And when we delve into her medical history, we find she has hypertension and type 2 diabetes mellitus.
Right, two big ones.
They are. These are more than just, bullet points on a chart. They're significant details. Now, while they might not be the direct cause of her current chief complaint, they are absolutely critical considerations.
How so?
Well, for example, diabetes, as we know, can predispose patients to a whole range of vascular complications, peripheral artery disease, neuropathy. Things we'll definitely need to carefully differentiate later.
Okay.
And her hypertension also signals, a broader vascular risk profile. Now, she's apparently managing these conditions pretty well. She's taking lisinopril for the hypertension and metformin for her diabetes.
So she's complying with meds.
It seems so, which tells us she's engaged in her health, but importantly, it doesn't eliminate the underlying risks these conditions present.
Gotcha. And her occupation also gives us a crucial piece of the puzzle. She works as a waitress at a local diner.
Okay, prolonged standing.
Immediately. All right. Paints a picture of her daily life. A job that involves being on her feet, prolonged standing for many hours. We know that can be a major contributing factor. Acts like a constant gravitational challenge to the venous system.
Big time.
In terms of other habits, she mentions drinking 1 to 2 glasses of wine daily, maybe occasionally more on weekends. But, importantly, denies smoking or any illicit drug use.
Okay.
And her father died of liver cancer at 61. It's a family history detail, worth noting for a complete picture, though probably not immediately relevant to her leg swelling right now. But it just reminds us to always consider that broader context.
Good point. Always keep the whole patient in view. What's truly fascinating here is how all these seemingly disparate elements, her meds, her chronic conditions, her job, they start to weave together a coherent narrative that helps us interpret the physical findings.
Right, the pieces start fitting.
Exactly. Now, moving to the physical exam, we start with her vital signs: temperature, heart rate, blood pressure, respiratory rate, all within normal limits.
That's reassuring.
It is.
Yeah.
It tells us she's not in an acute, life-threatening crisis, which might demand totally different immediate interventions. We also note her lungs are clear to auscultation. No crackles, no wheezes.
Okay.
Her cardiac examination shows no murmurs, no gallops, no rubs. Her abdomen is soft, non-tender, no organomegaly, so no enlarged liver or spleen.
And why are those negative findings so important?
Because they help us systematically rule out other systemic causes of leg swelling. Things like congestive heart failure, you'd expect maybe lung crackles or a gallop. Significant kidney disease often causes more generalized edema. Liver disease might show up with ascites or an enlarged liver. So by methodically checking these systems and finding them normal, we're effectively narrowing our diagnostic focus. We're zeroing in.
Okay, so where do we zero in? This is where it gets really compelling, because the core problem, the epicenter of her symptoms, is clearly localized to her lower extremities.
All right, let's hear the details.
The examination reveals 1+ pitting edema. It's in both lower extremities, extending up to about the level of the calves. But here's a very important distinction. There's relative sparing of the feet.
Ah, that distribution clue again. Very important.
Exactly. The fact that her feet aren't as swollen as her calves, that's a critical clue. It immediately starts to differentiate this type of edema from others. Beyond just the swelling, there are several dilated, compressible, tortuous veins. You can see them, you can feel them. They measure around 45 millimeters over both lower extremities.
Classic varicose veins, unmistakable.
Right. And indicative of some chronic irritation or discomfort, there are multiple excoriation marks, basically. Scratch marks noted over both ankles.
Suggests itching, pruritus.
Yeah, intense itching or chronic irritation. But the most concerning finding, and arguably the most advanced sign here, is a 2x2 centimeter ulcer. It has a shallow base and irregular edges, and it's located over the medial surface of the left ankle.
Medial ankle ulcer. Okay, alarm bells for a specific type.
Definitely. This isn't just a cosmetic issue. It's a clear, unequivocal sign of advanced disease progression.
And if we connect this to the bigger picture, the lab work and diagnostic results, they further refine our understanding and give us crucial exclusionary evidence.
What did they show?
Her serum glucose, urea nitrogen, creatinine, D-dimer concentrations, and liver function tests are all within reference ranges.
So all normal.
Essentially, yes.
Yeah.
And this is incredibly important. The normal glucose suggests her diabetes is, reasonably controlled, not causing acute issues. Normal urea and creatinine rules out significant kidney dysfunction causing the edema.
Right.
And a normal D-dimer is a powerful indicator that she does not have an acute blood clot, like a deep vein thrombosis or DVT.
Always a concern with leg swelling.
Always. But this test helps rule out an acute DVT. And normal liver function tests confirm that liver disease isn't contributing to her swelling either. So these negative labs, they let us confidently move past a whole host of systemic causes.
Okay, so we're really focusing locally now.
Precisely. But the truly crucial piece of information, the one that acts as a definitive diagnostic filter, comes from a simple, non-invasive test. The ankle brachial index, or ABI.
Ah, the ABI. What was it?
It's measured at 1.1 bilaterally.
1.1. And for those listening, that's a normal ABI.
It's exactly a perfectly normal ABI, and this is a vital piece of information. It helps us immediately start differentiating between various vascular conditions and, maybe even more importantly, ruling out others. It's a seemingly small detail, but it carries immense diagnostic weight.
So there you have it. A complete, detailed picture of our patient. Persistent leg swelling, worse through the day, spares the feet. Prominent varicose veins, that ulcer on her medial ankle, history of well-managed diabetes and hypertension. But crucially, normal labs in that normal ABI.
A very specific constellation.
Given this entire constellation of findings, what's the most appropriate next step in managing her condition? This is where the aha moments really begin, as we sift through the possibilities and learn to deftly avoid those common exam traps and clinical misdirections.
Right. To answer that pivotal question, the most appropriate next step, we first need to thoroughly unpack these symptoms. Each detail is a clue, really leading us directly to the most likely diagnosis. Let's start with the edema. The 1+ pitting edema, extending up to the calves, sparing the feet. That specific feature, combined with her reporting that the swelling noticeably worsens throughout the day and improves with rest, it immediately points us towards a specific type of vascular issue, chronic venous disease.
Okay.
What's truly fascinating here is how the specific distribution of the edema, that gravitational pattern, the relative sparing of the feet, it's a subtle but really powerful clue.
So why is that particular distribution the sparing of the feet? Why is that so significant? Especially for our audience who knows some basics. What's the physiological differentiator there?
That's an excellent question, and it's a really key insight for differentiating edema types. Think of it this way. Systemic causes of edema, like heart failure, severe kidney disease, advanced liver disease, they tend to cause a more generalized fluid overload, right?
Yeah, like fluid everywhere.
Exactly. Gravity pulls fluid everywhere down, leading to this diffuse edema that usually affects the feet and ankles most prominently and pretty uniformly. It's like a bathtub overflowing, water fills from the bottom up. Even lymphedema, while often asymmetric, usually involves the foot initially.
Okay.
However, in chronic venous insufficiency, the problem is more localized. It's in the venous system, in the calf and thigh, primarily affecting the larger saphenous veins and their tributaries. The foot's smaller venous network and its different muscular pump actions are often less affected initially, or at least the elevated pressure isn't as uniformly distributed right down to the toes.
Oh, I see.
This leads to that characteristic sparing effect of the feet, particularly when the main reflux, the main backflow, is in the saphenous system higher up the leg. It's a direct consequence of the localized valve dysfunction in the calf and thigh veins.
And the mechanism behind this specific type of edema is pretty clear then. It's not just fluid overload, it's more about pressure dynamics, right?
Precisely. In venous insufficiency, those little one-way valves inside the veins, they don't function properly. Imagine them as a series of gates, ensuring blood only flows upwards against gravity back towards the heart.
Okay.
When these gates are leaky or broken, incompetent, blood starts to pool in the lower extremities, especially when you're standing. This pooling dramatically increases the hydrostatic pressure within the capillaries in the lower leg.
Pushes fluid out.
Exactly. This elevated pressure forces fluid, the plasma part of the blood, out of the capillaries and into the surrounding interstitial tissues. And that results in that characteristic pitting edema. The gravitational effect explains why it gets worse through the day, especially with prolonged standing, and why it tends to improve overnight or with leg elevation. It's just a continuous battle against gravity with faulty plumbing.
Makes sense.
Now next, let's consider those dilated, compressible, tortuous veins, the 4 or 5 millimeter ones. These are classic varicose veins, a direct, unmistakable visual sign of venous incompetence.
Right, you can see the problem.
You can. They're essentially veins that have become enlarged, twisted, visibly prominent because of chronic increases in venous pressure, leading to persistent valve failure and that blood pooling. These aren't just cosmetic. They really signify underlying dysfunction.
And the connection to her job.
And when we connect this to her occupation as a waitress, requiring prolonged standing, we see a clear and potent contributing factor. Standing for long periods puts significant sustained strain on the venous system. Gravity is constantly working against the flow of blood back to the heart, exacerbating venous hypertension, and ultimately accelerating the development or worsening of varicose veins in people who are susceptible. It's a classic occupational hazard for this condition.
Okay. Then there's the ulcer. That 2 by 2 centimeter ulcer, shallow base, irregular edges, over the medial surface of the left ankle.
Location, location, location.
It's not just any skin lesion, it's a hallmark of advanced disease. The location medial surface of the ankle is a typical, almost diagnostic site for venous ulcers.
Why there specifically?
That area, often called the gator area, is particularly susceptible to the effects of chronic venous hypertension. The perforator veins in this region, which connect the superficial veins to the deep system, often become incompetent. This leads to localized pockets of very high pressure right under the skin.
Oh, okay.
And the characteristics shallow base, irregular edges, are crucial for distinguishing it from other ulcer types, which we absolutely need to get into.
Will.
And those excoriation marks we mentioned over both ankles. They suggest pruritus, intense itching. That's very common with the chronic skin changes you see in advanced chronic venous disease, something called stasis dermatitis.
Right, the skin gets inflamed, discolored.
Exactly. Often brownish, thickened, easily irritated, and super itchy because of that chronic inflammation and fluid leakage. The itching leads to scratching. The excoriations can break the fragile skin even more, and that can potentially lead to the ulcer itself or infection.
A vicious cycle.
Totally. And finally, let's just reiterate the critical role of that normal ankle brachial index. You called it a huge neon sign earlier, and it really acts as a powerful diagnostic filter.
It really does. Here's where it gets compelling and lets us narrow the field dramatically, avoiding a major exam pitfall. That ABI of 1.1 bilaterally, it's a seemingly small number, but it's fundamentally important because it effectively and decisively rules out significant peripheral artery disease, PAD, as the primary cause of this patient's leg symptoms.
Not just a hint, it's strong evidence against PA.
It really is. It's a strong refutation of an arterial problem being the main driver here.
Okay, just for everyone listening, especially those who might want a quick refresher or really want to solidify this, could you briefly explain what the ABI precisely measures and why that normal range is so critical here for differentiating these vascular conditions?
Certainly. The ankle brachial index, the ABI, it's a simple, non-invasive, but incredibly powerful diagnostic test. It compares the systolic blood pressure measured at the ankle to the systolic blood pressure measured up at the arm, the brachial artery.
Okay, ankle pressure divided by arm pressure.
Exactly. And the ratio you get is the ABI. A normal ABI typically falls between 1.0 and 1.4. An ABI of 0.9 or less is generally indicative of peripheral artery disease, PAD. It means there's significant narrowing or blockage in the arteries supplying blood down to the legs and feet, impeding blood flow.
Lower number means worse arterial flow.
Generally, yes. Conversely, an ABI greater than 1.4 can sometimes indicate non-compressible arteries, often seen in diabetic patients due to calcification of the artery walls. But even that finding rules out significant obstructive PA as the cause of her current symptoms like the ulcer.
Right.
So our patient's ABI of 1.1 bilaterally unequivocally means her arterial blood flow down to her lower extremities is perfectly healthy. This is a vital diagnostic differentiator because, yes, many things can cause leg ulcers, but ruling out the arterial component immediately steers us away from a whole set of diagnoses and management strategies.
Crucial step.
It tells us, whatever is causing her symptoms, it's not primarily a problem with her arteries. And overlooking this detail, classic exam mistake. Many people see ulcer and diabetes and just jump to PAD, but the ABI says no.
Okay, this detailed analysis of our patient's symptoms, the exam, the labs, the ABI, it raises an absolute critical question, especially for anyone navigating complex cases or, those high-stakes exams. When we see an ulcer on the leg, particularly in someone with diabetes like our patient, our minds might jump to several possibilities. Is it venous? Is it arterial? Is it neuropathic?
The big three for leg ulcers, usually.
Exactly. But the devil is truly in the details. Understanding the distinct, defining features of each ulcer type is where we really master this information, move beyond just surface-level understanding, and avoid those common exam traps.
We should use the classic comparison, right? Venous, arterial, neuropathic ulcers, like you see in textbooks or review materials.
Absolutely. Let's start by reinforcing why venous ulcers are unequivocally the strongest candidate for our patient. We've kind of built the case already. Yeah, lay it out systematically.
Okay. Underlying cause: chronic venous insufficiency. Supported by her history prolonged standing as a waitress, supported by the physical exam, those dilated, tortuous veins, the varicose veins, and that characteristic pitting edema that worsens through the day. Check, check, check.
Right.
The appearance of her ulcer, shallow base, irregular, often kind of sloping edges. That perfectly matches the classic description of a venous ulcer. These often look wet, maybe with some yellowish fibrinous stuff on the base.
Okay.
Its location, medial surface of the left ankle, classic. Textbook location for venous ulcers in that gator area we mentioned.
Okay.
Furthermore, the skin changes often seen around venous ulcers, that brownish discoloration from hemosiderin deposition.
Like rust stains under the skin.
Kind of, yeah. It's iron from broken down red blood cells that leak out and stain the tissue. And you see scaling, dryness. Our patient's excoriation marks strongly suggest itching, pruritus, which is super common with these skin changes, often called stasis dermatitis. The skin around the ulcer typically feels warm too, not cold, and you might see lipodermatosclerosis.
That's the hardening, right?
Exactly. A thickening and hardening of the skin and subcutaneous tissue from chronic inflammation and fibrosis sometimes gives the lower leg that inverted champagne bottle shape.
Okay.
And while they're often painful, the pain of a venous ulcer is usually described differently from arterial pain, more of an aching, heaviness, maybe burning, often feels better with elevation. And importantly, these ulcers are almost always associated with other signs of venous disease, the edema, the varicose veins, all of which are present in our patients.
So literally every single piece of her clinical puzzle, the edema type, the varicose veins, the ulcer's location, its appearance, even the scratch marks, it all aligns perfectly with a venous ulcer diagnosis.
It really does. Now, let's sharply contrast that with arterial ulcers and explain with absolute clarity why this is incorrect for a patient, despite her having risk factors like hypertension and diabetes. This is a critical distinction, especially for exams.
Yeah, why is this definitely not arterial?
Okay, primary underlying cause of arterial ulcers. Impaired arterial blood flow, usually from peripheral artery disease, PAD, atherosclerosis, blocking the pipes, essentially.
Right.
The key differentiators, the reasons it's not an arterial ulcer here, are numerous and undeniable. First and foremost, her ABI is 1.1, normal. Arterial ulcers are almost universally associated with a low ABI, typically 0.9 or less.
Number one reason.
Absolutely. This single finding is critical. Overlooking it is a major MCQ trap. Students see ulcer, diabetes, think arterial, ignore the ABI, huge mistake. The ABI here provides undeniable counter-evidence. Dismiss this option confidently.
Besides the ABI.
Appearance. Arterial ulcers usually look very different. They often have regular, sharply defined, punched-out margins, like someone took a hole punch to the skin. Often circular or oval, they're typically deeper than venous ulcers, sometimes exposing tendons or even bone. And the base. Often pale, necrotic, maybe black or gangrenous, not shallow and granular like hers.
Completely different look.
Totally. And location is different too. Arterial ulcers commonly pop up on the tips of the toes, the lateral malleolus, that outer ankle bone, or over pressure points on the foot where blood supply is already tenuous, rarely on the medial ankle like hers.
Okay.
The skin changes with PAD are also distinct, telling a story of ischemia, lack of blood flow. You see pale, shiny, thin, atrophic skin, reduced hair growth on the leg and foot, maybe muscle atrophy. The skin often feels cold to the touch. Nails might be thick and brittle. None of these are described for a patient.
Right, opposite findings almost.
Pretty much. Patients with significant PAD also typically have absent or markedly weak pulses in their feet, the dorsalis pedis, posterior tibial. While her exam didn't explicitly state pulse quality, that normal ABI strongly implies robust arterial flow, so good pulses.
Makes sense.
Finally, pain. Arterial ulcers are often very painful. A severe, constant throbbing pain often gets worse when they elevate the leg because that reduces blood flow even more. Sometimes feels a bit better if they dangle the leg over the side of the bed. Different quality and pattern of pain than typically described for venous ulcers.
Okay.
So the MCQ trap here is classic. Failing to integrate the ABI result or misinterpreting the ulcer appearance based on general risk factors like diabetes rather than the specific findings in this patient. You should never choose treatments for PAD like clopidogrel or silestazol without definitive diagnostic evidence of PAD. Her ABI clearly refutes it.
That's a crucial and really comprehensive distinction. It highlights how one test, the ABI, can just pivot the whole differential. Now, what about neuropathic ulcers? Our patient does have type 2 diabetes, which definitely makes her susceptible to diabetic neuropathy. So why is this incorrect for her? What are the key differences?
You've hit on another major MCQ trap that gets a lot of people. It's so common to automatically assume an ulcer in a diabetic patient must be neuropathic just because diabetic neuropathy is so prevalent. But again, the details of the presentation are paramount.
Okay. What are the key differences?
The underlying cause for neuropathic ulcers is diabetic neuropathy, specifically that symmetrical sensory loss of protective sensation in the feet. Without that feeling, patients often don't notice repetitive trauma or pressure leading to skin breakdown.
Right, they can't feel the injury happen.
Exactly. And the most significant differentiator often is pain. Neuropathic ulcers are characteristically painless because the nerves that sense pain are damaged. Patients literally cannot feel them. Our patient's description includes excoriation marks around her ankles, suggesting itching, and the general painful nature described for venous ulcers due to inflammation and skin compromise. It strongly implies her ulcer is painful. That powerfully argues against a primary neuropathic cause.
Location too?
Location is also very specific and different. Neuropathic ulcers typically form over pressure points on the foot. Think plantar surface, the bottom of the foot. Metatarsal heads the balls of the feet, the heels, or sometimes associated with Charcot foot deformities. These are areas subjected to repetitive stress during walking and standing. Fundamentally different from our patient's medial ankle ulcer.
Okay.
Associated skin changes might include dry, scaly skin, maybe cracked calluses due to abnormal pressure and lack of sweating. That's autonomic neuropathy. You might also find decreased deep tendon reflexes, or again, not the primary findings described in her leg. So the MCQ trap is precisely that. automatically assuming an ulcer in a diabetic patient is neuropathic without thoroughly considering all the other symptoms, the ulcer's specific characteristics, its location, and whether it's painful or not. It highlights the absolute need for a comprehensive, holistic evaluation, not just a quick jump based on one comorbidity. Always challenge your initial assumptions with the full clinical picture.
So if we connect this all back to the bigger picture, really distill it down, all the signs in our patient's case, the specific edema pattern, the visible varicose veins, the ulcer's location and appearance on the medial ankle, and especially that rock-solid normal ABI, they are unequivocally pointing to chronic venous disease.
Screaming it almost.
Yeah. Specifically in advanced form, given the ulceration. This meticulous differential diagnosis, it isn't just an academic exercise, it's absolutely critical for avoiding those exam pitfalls, for steering clear of misdiagnosis in real-world practice, and for confidently guiding us to the most appropriate, effective next step for our patient.
Exactly. Now that we've confidently identified the likely underlying condition as advanced chronic venous disease and critically ruled out arterial and neuropathic causes, let's scrutinize those proposed management steps.
Okay, the options.
This is where so many common exam mistakes happen, because the options often sound plausible, but they're incorrect for subtle yet absolutely critical reasons based on current evidence-based guidelines and the natural progression of this disease. We'll go through each option methodically, explain not just what they are, but why they fit, or more importantly, don't fit our patient's precise clinical scenario and what common traps they represent.
Let's do it. Start with option B.
Let's start with option B, clopidogrel and cilostazol therapy. Okay, this choice is definitively wrong. Selecting it represents a major exam mistake, demonstrating a lack of precise differentiation between vascular conditions.
Why so definitively wrong?
Clopidogrel is an antiplatelet drug, primary use, preventing arterial blood clots in patients with atherosclerosis, like after a heart attack or stroke, or with PAD. Cilostazol is a phosphodiesterase inhibitor. It acts as a vasodilator and also has antiplatelet effects. It's specifically approved for treating intermittent claudication, that cramping leg pain with walking in patients with peripheral artery disease, PAD.
Okay, so both are for arterial problems.
Fundamentally, yes. They address problems with arterial blood flow or arterial thrombosis. But as we've thoroughly established, our patient's symptoms, the pitting edema, the varicose veins, the medial ankle ulcer characteristics are not consistent with PD.
Right.
Her ulcer is shallow, irregular edges, medial ankle classic venous, not the punched-out, deep toe tip or lateral ankle ulcers of PD. Her skin findings imply warmth, maybe stasis dermatitis, opposite of the pale, shiny, cold, hairless skin of PD.
And the big one.
And crucially, that normal ABI of 1.1, it definitively makes PAD extremely unlikely as the cause of her current symptoms. So giving these medications would be inappropriate, offer no benefit for her venous disease, and carry unnecessary risks like bleeding.
Makes sense.
Selecting this option is a classic MCQ trap. It preys on that general association. Vascular disease must mean antiplatelets needed, without precise differentiation between arterial and venous. Easy trap to fall into. Critical exam mistake to choose PAD treatments without evidence of PAD.
Okay, that's crystal clear. A great example of needing diagnostic precision.
Yeah.
Next up, let's look at option A, sclerotherapy. Why is this incorrect as the immediate next step for our patient?
Okay, sclerotherapy. It is a recognized form of vein ablation therapy, or VAT. You inject a solution, liquid or foam, directly into varicose veins.
Yeah, I see that.
The sclerostin irritates the vein lining, causing it to scar down, collapse, disappear eventually. It's definitely a treatment option for varicose veins, particularly maybe smaller ones, reticular veins, spider veins.
Not for her right now.
But it's incorrect as the immediate next step for this patient who presents with advanced chronic venous disease, including that active venous ulcer, for several really crucial reasons.
Okay, where are they?
First, while sclerotherapy has its place, current guidelines for treating significant saphenous vein reflux, which is often the underlying cause of large varicose veins, and CVI generally prefer endovenous thermal ablation, EVTA. That's using either laser, EVLA, or radiofrequency, RFA.
Key to close the vein.
Exactly. It's generally preferred over sclerotherapy as a first-line interventional procedure, especially for the larger main saphenous veins. Why? Often lower recurrence rates, better long-term efficacy, maybe fewer complications compared to sclerotherapy for those big truncal veins. Sclera can have issues like skin staining, phlebitis, even rare but serious things like skin necrosis or DVT stroke with foam.
Okay, so maybe not the best type of intervention, but is that the main reason it's wrong here?
Not the main reason it's wrong, as the next step. More importantly, this option completely overlooks a fundamental diagnostic prerequisite. Even if we were thinking about any form of vein ablation therapy, sclerotherapy, thermal ablation, whatever the guidelines are crystal clear, another crucial diagnostic step is required before you proceed with any form of VAT.
Jumping the gun.
Totally. Jumping directly to an interventional procedure without this prerequisite step. It's inappropriate, potentially ineffective, could lead to suboptimal outcomes because you haven't fully mapped out the underlying problem first. You wouldn't fix a leaky pipe without knowing precisely where the leak is originating, right?
Makes perfect sense. You need the map first.
Okay.
Now, for what the source material suggests is a major exam trap. A very common incorrect answer. Option D, compression stocking therapy. Apparently, a huge percentage, like 67% of test takers, choose this one.
Ah, yes, the siren song of compression.
Why is it wrong as the most appropriate next step for this specific patient?
Yeah.
Especially when we know compression is like the cornerstone of venous disease management. It feels so intuitive, which makes it a truly clever trap.
It is a classic good answer, but not the best next answer trap. And it highlights a critical misunderstanding of the sequential, guideline-driven management of advanced chronic venous disease. Compression stocking therapy, applying that external graduated pressure, is absolutely fundamental, no question.
So why not start with it?
It helps support vein walls, reduce pooling, decrease edema, improve venous return, helps ulcers heal. It will absolutely be part of her long-term care. However, it's primarily appropriate as the definitive initial step only for patients with mild chronic venous disease.
Define mild here.
Specifically, those with only symptoms like varicose veins or edema, maybe CEP class C2 or C3, without a definitively identifiable and correctable cause of significant reflux found on imaging. Or in specific scenarios like pregnancy, where we often postpone interventions.
Okay, but our patient?
Our patient has advanced CVD, evidenced unequivocally by the presence of that venous ulcer, CEAP class C6. An ulcer signifies significant disease progression. It means the underlying venous reflux is severe enough to cause sustained, high-pressure, skin breakdown, tissue damage. For advanced CVD like this, just applying symptomatic compression is not sufficient as the most appropriate next step.
Why not?
Because, regardless of the severity, current guidelines from all major vascular societies unequivocally recommend that any form of definitive treatment, and that includes long-term compression therapy if it's the sole treatment planned, must be preceded by a specific diagnostic step.
The map again.
The map again. This diagnostic step is essential to thoroughly identify the underlying cause of the venous reflux and, crucially, to determine if that reflux is correctable through interventional means. So while compression is vital and will be used, it is not the first or most appropriate next step when a patient walks in with an established venous ulcer. Jumping to treatment without a full, detailed diagnostic map of the venous system is a significant exam mistake. People misunderstand the distinction between mild versus advanced CVD, or they forget the required sequence. Diagnose thoroughly, then treat appropriately.
Okay, sequence and completeness. Diagnosis before definitive treatment, especially when it's advanced disease. Got it. Let's move to option E, contrast venography. This sounds highly sophisticated, very detailed. Why is it generally incorrect for the initial workup here? What are its niche uses?
Contrast monography is sophisticated. You inject radiopaque contrast dye directly into the veins, take x-rays, gives you beautiful anatomical detail of the venous system, shows morphology, blockages, clots very clearly.
Sounds useful.
It can be, but despite its detail, it is rarely the answer for initial workup in chronic venous disease, especially now with modern non-invasive imaging.
Why not?
Current guidelines do not recommend it for routine studies of CVD. For several reasons. Its invasive requires IV access, injecting dye. It carries risks associated with the contrast dye itself, allergic reactions, kidney injury, contrast-induced nephropathy. There's radiation exposure. And it's not as easily accessible or cost-effective as other safer methods, namely ultrasound.
So when is it used?
Typically only reserved for very specific, more complex circumstances. Like if the initial non-invasive imaging, the ultrasound, is inconclusive or gives contradictory results, or if you have a strong suspicion of something less common like intra-abdominal or pelvic venous obstruction causing the leg issues, think May-Thurner syndrome, where an artery compresses a vein in the pelvis. Venography is great for diagnosing that. Or maybe for very detailed preoperative planning in highly complex or recurrent cases where ultrasound hasn't provided enough info.
But not for a standard case like this first time around.
Exactly. If we connect this to the bigger picture, modern medicine strongly prioritizes non-invasive, cost-effective, safe diagnostics first. Jumping to an invasive, higher-risk procedure like phenography without exhausting the simpler, safer, universally recommended options. Almost never the appropriate first step in the diagnostic algorithm for routine CVD. It's another MCQ trap, presenting an advanced, specialized tool that's usually reserved for complex situations, not the initial foundational workup.
All right, we have systematically dismantled why 4 of the 5 options are incorrect, inappropriate, or just not the immediate next step. That leaves us with option C, duplex ultrasonography. This then must be the correct answer. Let's dive deep now into why it's not just an option, but the most essential and appropriate next step. Why is it the diagnostic key that unlocks the correct treatment pathway?
Absolutely. Duplex ultrasonography. It's non-invasive, highly versatile, and truly the gold standard for evaluating the venous system in this context. It combines two powerful ultrasound modalities.
Duplex meaning 2.
Exactly. It uses conventional B-mode ultrasound, which lets us visualize the physical structure, see the veins, identify clots, thrombi, assess vein wall thickness, and it combines that with Doppler ultrasound, which lets us assess blood flow, the direction and velocity of blood within those veins. This dual capability is what makes it so incredibly powerful and indispensable.
Okay, so why is it the most appropriate next step here?
Current guidelines are unequivocal, crystal clear. All patients suspected to have chronic venous disease, and especially those with advanced disease, like our patient with a venous ulcer, should undergo duplex ultrasonography before any definitive treatment is initiated. Period. It's the foundational diagnostic step, the cornerstone upon which all subsequent management decisions are built. You simply cannot bypass this for an advanced case like hers.
What's its main job?
Its primary goal, its key purpose one, is to precisely identify if there is a correctable cause of venous reflux, particularly in the superficial venous system like the great saphenous vein, small saphenous vein, or in those perforator veins connecting superficial to deep.
Remind us what reflux is again, technically.
Right. Think of those one-way valves in your veins as gates ensuring blood flows only up, towards the heart. In venous insufficiency, these gates are leaky, broken, incompetent. So when you stand or walk, gravity pulls blood down, but these faulty valves can't stop it. Blood flows backward. That's reflex. It pools in the lower leg.
The root cause.
It's the fundamental problem driving that high venous pressure, venous hypertension, which ultimately leads to the varicose veins, the edema, the skin changes, and critically, the ulcer formation. Duplex ultrasound can pinpoint exactly where these incompetent valves are. It can measure how long the blood flows backward, how fast it flows backward, quantify the severity of the reflux.
And its second key purpose.
Leads directly from the first. Key purpose 2. It's absolutely essential for planning any interventional procedure. If that duplex scan identifies significant correctable reflux, then a procedure like endovenous dermal ablation or maybe sclerotherapy might be considered. The duplex provides a precise anatomical and physiological map.
The map we needed.
Exactly. It identifies the specific superficial, deep, and perforator vein sites that are incompetent. It shows their diameter, their exact location, their relationship to other structures. Without this detailed map, any intervention would be haphazard, potentially ineffective, maybe even harmful. You need to know which vein segment is refluxing and where to target your intervention.
So it dictates the treatment choice.
It guides it significantly. This step logically precedes sclerotherapy, option A. You need the map to know where to inject if sclero is even the best option for that vein size and location. It also informs whether compression therapy, option D, alone is sufficient, or if an intervention to fix the reflux is really needed for durable healing and to prevent recurrence. For a patient with an ulcer, finding correctable reflux on ultrasound strongly favors adding an interventional approach to the compression therapy. So the MCQ lesson here is vital. This choice demonstrates the importance of a systematic, guideline-driven diagnostic approach, especially when advanced disease like an ulcer is present. It's the diagnostic key. It unlocks the correct, most effective treatment pathway, ensures treatments are targeted, evidence-based, address the root cause, not just mask symptoms. It's not just about finding an answer. It's about finding the right answer in the right sequence. Hashtag broader implications and mastery of CVD management.
That's a phenomenal, incredibly thorough explanation of why duplex ultrasonography is so critical.
Yeah.
It really underscores the importance of that methodical, step-by-step approach in medicine, resisting the urge to just jump ahead. Let's zoom out a bit now, look at the broader implications. How does working through this case help us achieve true mastery of chronic venous disease management?
Indeed. Understanding this case lets us construct a clear, pretty universal diagnostic pathway for CVD. It always starts with clinical suspicion, generated from the patient's history that worsening lead swelling with standing, and the physical exam varicose veins, edema, skin changes, ulcers.
Okay, step one, suspicion.
Right. Once that suspicion is high, like it was with our patient, the next step, the absolute gold standard for confirming the diagnosis, precisely identifying the specific etiology, mapping the extent of the disease, is undoubtedly duplex ultrasonography.
Step two, the map.
The map. It unequivocally confirms the presence and location of venous reflux, critical for planning interventions. Then, and only then, can we move to tailored treatment, based on those precise ultrasound findings and the overall severity of the disease. This systematic approach is what prevents misdiagnosis and ensures effective treatment.
So what does this all mean for you, our learner? Understanding what unequivocally constitutes advanced CVD is critical. Our patient had an ulcer, right, which automatically put her in that category. And that changed the entire diagnostic and management game, didn't it?
Wow.
If she only had varicose veins, say, the urgency or the immediate next step might have been different.
Absolutely, that distinction is paramount. The presence of a venous ulcer is a clear, unequivocal indicator of advanced chronic venous disease. We often classify it using the CEAP system: clinical, etiological, anatomical, pathophysiological. An active ulcer is C6, the most advanced clinical stage.
C6.
This distinguishes it significantly from milder forms. Someone might just have spider veins, C1, varicose veins, C2, or just edema, C3, without skin breakdown or ulceration. This distinction dictates the necessity and urgency of that full diagnostic workup, specifically duplex ultrasound before definitive treatment. For mild CVD, maybe conservative management is enough for a while, but an active ulcer drastically elevates the urgency, mandates a diagnostic ultrasound to look for a correctable cause. The deep insight here is that venous disease management is rarely just one single fix. It's more like a multi-layered approach, a treatment pyramid, if you will. Lifestyle is the base, compression is the next layer up, and targeted intervention sits at the apex, but only for specific cases with proven correctable reflux. You don't just jump straight to the apex without assessing the foundation and middle layers.
That brings us really nicely to the treatment continuum in CVD. It involves a combination of strategies tailored to the individual and their disease severity. Right?
Precisely. Let's talk conservative management. This is appropriate for mild CVD, maybe no correctable reflux found, or during pregnancy when we often wait. The mainstays: consistent compression therapy, often graduated compression stockings.
Those tight socks.
Exactly. Ideally prescribed with the right pressure gradient, maybe 20-30 millimeters G, maybe 30-40 millimeters G at the ankle, depending on severity. They help reduce pooling, decrease edema, support the veins. Beyond stockings, daily exercise is huge, activates the calf muscle pump, improves venous return, regular elevation of the legs, ideally above the heart, and avoiding prolonged standing or sitting, all crucial to reduce venous pressure and symptoms.
Okay, that's conservative. What about intervention?
So for patients like ours, where duplex ultrasound does identify significant correctable reflux in the superficial or perforator veins, we then move towards interventional management. Options here primarily include that endovenous thermal ablation, EVTA, laser, or radiofrequency, often preferred over sclerotherapy for the bigger saphenous veins, remember? Lower recurrence, maybe higher efficacy.
Right, heat to close the
Yep. These procedures use heat to basically seal off the damaged vein from the inside. Blood then gets redirected to healthier veins. Other procedures exist too: phlebectomy, which is surgical removal of varicose veins through small incisions. Or sometimes, though less common now, surgical ligation and stripping. But remember, these interventions come after the diagnostic ultrasound map dictates the approach. They address the root cause of the reflux.
And it's absolutely crucial to remember that lifestyle advice, that's always relevant, right?
Yeah.
Regardless of severity or interventions, it's not just a nice to have.
Oh, absolutely fundamental, and honestly, often an undervalued component of management. Those lifestyle modifications, daily exercise, activating the calf pump, regular leg elevation counteracting gravity, actively avoiding prolonged standing or sitting, which just exacerbates venous hypertension, they're always a core component of management for all patients with CVD. Doesn't matter how severe, doesn't matter if they're getting ablation or just wearing stockings.
Empowers the patient too.
Exactly. It's about empowering the patient to actively manage their condition, slow disease progression, alleviate symptoms, and help prevent recurrence. That patient education piece is critical for long-term success.
Why mastery matters here is just so clear now. This case highlights that intricate interplay, the nuanced clinical presentation, the strategic use of the right diagnostic tools at the right time, and sticking to evidence-based guidelines. Mastering this lets you avoid those common traps, make precise diagnoses, and ultimately provide optimal, patient-centered care that truly addresses the underlying problem, not just the symptoms. It's really about building that robust clinical reasoning muscle. Hashtag Chag Outro. What an incredible deep dive, seriously. We started with this complex patient presentation, carefully navigated through those critical differential diagnoses,
Yes.
venous, arterial, neuropathic, and meticulously dissected why each potential management step was either spot on or, more often than not, a very clever misdirection.
Yeah, lots of potential pitfalls there.
Definitely. The main overarching takeaway, I think it has to be this. When you're faced with advanced chronic venous disease, especially with the concerning presence of a venous ulcer, a comprehensive diagnostic roadmap, starting definitively and unequivocally with duplex ultrasonography to identify correctable reflex, is not just a recommendation. It's non-negotiable.
Absolutely. It's the essential first step to get to truly targeted and effective treatment. And, this deep dive into venous disease management, it isn't just about identifying the right test at the right time. It's really about understanding the insidious progression of a chronic condition and the crucial, often underestimated, role of proactive patient education and potentially earlier intervention.
Mhm.
It raises an important question, I think, for all of us listening and learning. How might more aggressive, proactive lifestyle interventions and maybe earlier, precise diagnosis, perhaps identifying and treating significant reflux before ulceration ever occurs, how might that dramatically alter a patient's long-term quality of life and potentially reduce the need for more invasive, complex procedures down the line? It's a powerful thought, isn't it? It reminds us that the greatest mastery often lies in prevention, just as much as it does in intervention.